Right. So if you have read and understood, considering its surgical pathology patient, kindly tell me what are your differential diagnoses for this patient?
My differential diagnosis for this patient includes septic right knee septic arthritis. It could be chronic osteomyelitis. It could be gout, pseudo-gout. It could be rheumatoid arthritis.
Good. Right. Okay. How would you confirm your diagnosis?
I'll confirm my diagnosis by taking the right knee joint aspirate for microscopic culture and sensitivity tests.
What are the most common organisms that you can find in the aspirate?
Staphylococcus aureus. Staphylococcus aureus.
Okay. Any other? If it is
Yes.
staph epidermis, what would you interfere?
I didn't get ma.
What if it's some other organism? What are the most common organisms that you can find? What are the, okay, gram positives, and then what if it's staph epidermis? Yes.
Yes, ma'am. Staphylococcus epidermidis, Streptococcus viridans, Streptococcus pyogenes, Escherichia coli, Mucus influenzae can also be cultured.
Yes. If you find if you receive the result report after 2 weeks and you find that there are staph epidermidis as a result, so what would be your thinking? What would you be thinking then?
I'll be thinking
in which conditions you'll find this organism?
Direct inoculation of the microorganisms in osteomyelitis.
When there is presence of any implants or prosthetic. So yes, this patient was also had the knee plate inserted 3 years ago. So all right. So what would be, how would your differential diagnosis differ now once you have received the report?
Yes, well, first on my list will be chronic osteomyelitis because of the history of a surgery and the place that the patient has had.
Okay, can you tell me the pathogenesis of osteomyelitis, please?
Okay, osteomyelitis is caused by either hematogenously or directly inoculating the pathogenic microorganisms into the susceptible bone. After this is done, there's polymorphonuclear leukocytosis. The leukocytes they adhere, they transmigrate, and they move to the site of infection. After this is done, there is inflammation. There is tissue swelling. As a result of this, there is a consequent suppuration, which occurs as a result of accumulation of these polymorphonuclear sites, the dead and dying microorganisms, and their subsequent engulfing. There is an increase in the intraosseous pressure, and as a result of osmolality, this causes intense pain from the patient. Eventually, there is a give in the cortex of the bone, which causes this suppuration to track it and cause an elevation of the periosteum. Elevation of the periosteum stimulates the osteoblast, which results in the formation of new bones, which appears subsequently as which thickens and appears subsequently as a involucrum. The underlying bone, which is deprived of blood supply, which forms a sequestrum. There is an area of necrosis which propagates and forms a sequestrum. As a result of this, because of the increased intraosteal pressure, there is also further compromise of the blood supply, which further propagates the area of a dead.
Can you please tell me, whole this process takes approximately how many days?
The stage of inflammation takes 48 days. The stage of suppuration takes about 48 to 72 hours. The stage of necrosis and the sequestral formation takes about 1 week, and the involucrum and the subsequent discharging sign takes about resolution. And
that takes approximately two weeks,
2 weeks,
14 days. Okay, can you please tell me what are the ways or the pathways through which these microorganisms they infect the bone?
Yeah, they can infect the bone either through hematogenous route, which is commoner in children. They can infect the bone either through direct inoculation as a result of fractures, as a result of surgery. They can also be as a result of contiguous spread from, for example, septic arthritis.
What part of the bone is affected?
Metaphysis.
Okay.
More commonly.
Most commonly, right. Okay. All right. Can you please tell me, once there's pus formation, why the pus it bursts out through the bone?
Yes, I burst out through the bone, through an area in the involucrum, which is called the cloaca, and then this appears as a discharging sinus clinically.
Okay. Can you tell me, can you define the term necrosis?
Necrosis is death of a tissue pathologically.
Can you tell me how many types of cell death do you know of?
Yes, I know of necrosis. I know of apoptosis, which is programmed cell death, which will be physiological. Then necrosis, which is always pathological.
Okay, and there are two types, non-programmed cell death and programmed cell death. And if you can go ahead and give examples of each, can you please?
Yes, a programmed cell death could occur in the involution, for example, involution of the uterus following the parturition. Then necrosis occurs as a result of inhibition of growth of as a result of compromise of blood supply, which results in subsequent ischemia and necrosis of the tissue. So gangrene is also a form of cell death.
Can you tell me the difference between extrinsic apoptosis and intrinsic apoptosis? These are examples of what type of cell death?
Yes, these are examples of programmed cell death, apoptosis. The extrinsic apoptosis occurs on the exterior of the cell, and this is initiated by the death receptor, the fast ligands. The intrinsic apoptosis occurs as a result of the release of the lysosomal enzymes. As a result of lysosomal enzymes, it's also called the mitochondrial pathway, which is intrinsic within the cell.
How is that different from autophagic cell death?
Autophagic cell death is a cell digesting itself. It's as a result of a cellular swelling, as a result of compromise of the integrity of the cell membrane, and the intracellular organelles also lies, releasing intracellular digestive enzymes which digest the cell. That's autophagy.
Very good. So now that you know patient has infection, how would the management of this patient differ now? What would you do?
Yes, I will do a thorough physical examination of the patient. I will investigate the patient. I will do a C-reactive protein. I will do wound swab for microscopic culture and sensitivity test. I will do a radiograph of the affected knee, anteroposterior and lateral. I'll also do a magnetic resonance imaging. I'll do a full blood count plus peripheral blood film.
Now patient has infection, and you know it's I told you it's staph epidermidis. How would management differ now? Why is it important to remove the plate?
Yes, it's important to remove the plate because the plate serves as a focus of infection. And if it is not removed, the infection may not be curtailed because the microorganism will have formed a biofilm on the plate. Okay,
just suppose you did not remove the plate and patient has infection, chronic infection, till the point that there has become or developed a non-healing sinus, and that sinus has also became so bad that it has become squamous cell carcinoma. What would you do then? How would the treatment differ?
In that stage, the patient will have a biopsy for confirmation of diagnosis. Yes. A radiograph will be done, and yes. Also the patient will benefit from from chemotherapy. Patient can benefit from chemotherapy. Patient can also benefit from
while you have sent for biopsy, would you or would you not prefer giving antibiotics to the patient?
Yes, I will start giving broad spectrum antibiotics. Thank you, ma'am.
Yes, and then at the same time, you'll give the supportive medication to the patient for the pain, yes, and dehydration, yes, and
yes, and limb splintage.
You do the surgical drainage as well. Yes, limb splintage.
Yes, I also do limb splintage and sequestrectomy. and surgical drainage.
Yes, very good. So that ends. Thank you. You have well prepared. That was well prepared. I asked you everything, and I'm happy.